Hi, and welcome to the Keys to Therapy. Today's guest is Marie Seda. Hi, Marie.
You.
I'm good. How are you?
I'm happy to be here.
Oh, so happy to have you here. Do you want to tell the audience a little bit about who you are and what you do?
My name is Marie Seda, and I am a psychiatric mental health nurse practitioner, which is a long word that means people send patients to me to talk about medicine or to get on medicine.
Awesome. And I know I've sent you some people when we worked together in the past.
Thank you. Yeah.
Yeah. So for the audience, Marie and I worked together. We worked at different clinics, but we worked with the military. So I worked on base at one clinic and she worked at a different clinic, but we all kind of shared clients and, collaborated and stuff like that. So that's how I know her. So I figured for the new therapists out there, I know I for certain was never taught how to collaborate with prescribers, what to talk about, the importance of it, any of that. So I think it'll be really interesting to learn a little bit more about that today for everybody. But before we get started, if you want to just explain a little bit about why you chose this field, what made you want to become a nurse practitioner?
Well, I think that originally I wanted to just do therapy. I was always an emergency room nurse, and then I got involved with a clinic. With our primary goal, it was with the military clinic. We would identify women at risk for child abuse when they were pregnant, and then we would go in as a primary means of prevention. And if they were willing, we would go out and meet with them. We'd establish a therapeutic relationship and teach them. And we really had a lot of good research on how much it lowered their risk and the risk of child abuse, and increase the well-being of the mother. So with that in the emergency room, they'd always call me if there were tragedies, because in the emergency room, generally speaking, we don't like to do touchy-feely. If we can do it, but if a mom comes in and has laid and killed a newborn, nobody knows how to handle that. So I was called in for that because I just have an ability to sit with that type of pain, which I will tell you is from doing my own work. Therapist and doing years of work myself. That rendered me able to sit with other people in their pain. So anyway, I think that at first, coming from the emergency room, I thought, well, I'll become an FNP. But the more I looked at it from sort of a wide angle, the more I thought, I have a gift. I can do things that maybe other people are not as gifted with. To sit with people, being able to see the good where sometimes people don't, it's hard to find the good. And so that's when I changed to a very new and emerging field, which was psychiatry for nurse practitioners. There were none in the state of Virginia when I got here. So back in the day, I had to knock on doors and beg. And I just don't work, So I think, did I answer your question?
Oh, absolutely. I love that though, because it's like you were a trailblazer out here.
I was, yeah. Yep. And it was fun. I liked it.
Yeah, but then you're right. And being a woman too, and doing that and coming out. It's amazing.
Right. And, in the beginning, doctors didn't like that. So I really had to prove myself. I had to be humble, because when you get out of school, you don't know this stuff, so I had to be humble. I was there to learn, really. And they knew about me, the more they began to trust me. And so I think I did trailblaze in a good way.
Absolutely. And a necessary way too.
I agree.
Wow. Well, for, again, new therapists, a lot of us, when we're in school, like I said, we're not talked about or talked to about anything with medicine, except there was one class in particular where they had us memorize the list of like the commonly prescribed ones and then their generic names. And that was kind of the extent of it. So I'm sure there's electives or there's like further certifications and things people could take to learn about it. But I feel like therapists really don't have a good education in what medication is like. So for your process for running an assessment or an intake, what would that look like? What are you asking about and what are you looking for?
So, when people come to see me, I try to disregard any of their past diagnoses.
Okay.
How many people are misdiagnosed? And that's not, that might be by another doctor, could be by some testing done. So
Mhm.
an open mind with that. So I'm looking at the whole person. I think nurse practitioners in general like to look at the whole person, like therapists as well do. What's going on in their family? What brought them here? Have they been seen before? Have they been on meds before? And what happened? Has
Mhm.
anyone been on meds? What meds? And how did that work out? Because there's a big genetic, um, genes play a big role. So if your mom did good on Prozac, I'm going with Prozac unless there's something that keeps. I like to look at generations. Are there generations of people in the family? Anybody diagnosed with bipolar disorder? My big one. Or anybody been in and out of prison because of aggressive behavior? Anything that might reek of bipolar disorder? ECT or hospitalized for long periods of time, catatonic depression, things that might make me think, is there a bipolar type of flavor to that? Because to me, that's the most important thing. The medications we generally use for depression can worsen a bipolar disorder. So that's my big thing. Do I hear any of that? And then I want to rule out that there's not something medical that's causing these symptoms. Medical, nutritional, because I think we live in a nutritionally
Efficient.
error.
Mhm.
Processed foods, and the more processed foods we eat, the more our B vitamins are depleted. There's been studies that show that the amount of water, your regular drinking water, how much lithium is in it, because lithium comes from the ground. In areas where the lithium levels are low, you have more incidence of aggressiveness, depression, and suicidality. So, what we're taking in our bodies matters. I'm a big proponent of get rid of the bottled water, drink your water, but check your tap table and see if you're getting the right nutrients. Anyway, so that's basically what I'm doing. I want to know what's worked for people. Are there symptoms all the time? Are they situational? And how are they medicating yourself? Because all of us, if our dopamine is low in our brain, if our serotonin is low, we're going to medicate. We might not know that, but we're going to. If I'm anxious and I can't sleep, and maybe a glass of wine worked to help me sleep, well, probably we'll do that again, right?
Mhm.
Or weed, people smoke weed to try to manage symptoms. And so food, we been guilty. Food and sweets can kind of make our serotonin go up, not for long, but we're going to medicate them if we don't do something
I love
about
that you look at the whole person. I just love that because I feel like I know for me personally, even when I've gone to just like the regular doctor, it's just a checklist. Let's look at BMI. Let's look at, sleep, and it's just like very cold and not actually, nobody's really asking the questions. It just becomes like such a routine where you feel like the person that's asking you them isn't even really interested. They're just trying to get through their appointment. And I feel like even the way that you were talking about family history, generations in the past never really discussed like these details, right? So when you say like hospitalizations, like, oh, well, this one had a breakdown, or this person was like the crazy uncle, or whatever. But I like how you actually ask the questions about like these past generations and give examples of what you're looking for.
Yep, it's the only way that works. And that requires more time. So that's why I'm in my own private practice, so that I can take that time with people, because you can't get this in 30 minutes, 60 minutes. So I do 90 minutes. How I do it.
Yeah, that's awesome. Yeah, but that makes sense. And that's, I mean, how else are you going to get somebody's whole life history like that, and something with medication? And I like that you said specifically looking out for bipolar, because I feel like that's something that therapists might need to be doing more of too. And again, not necessarily taught. I mean, maybe asking a question about like mania. Do clients even know what that is? So it sounds like you really dig deep into like the symptomology and not just like the clinical labels.
Yeah. And bipolar is a word that's thrown around a lot.
Mm-hmm.
I have people come in and they're diagnosed with bipolar disorder, and then I don't see in their note, how did they get to this diagnosis? Because if you're going to diagnose me with bipolar disorder, I better see where you came to that conclusion. And it's not a checklist. Checklists are helpful. I do like screeners.
Mm-hmm.
If someone's improving, and show that to them. But they do not, we can't use them to diagnose someone. So, people can write, yes, 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 yes. But if you go through those yeses, well, okay, no, it's not that. So you also have to dig into that too.
Yeah. And then, like you said, looking at the situational component as well, because I always tell my clients, like, on any day, you can look like you have any disorder.
Right. And the more stress you have, the more disordered you're going to look. Right.
Exactly. Yeah. So I really like that, because I think it shows that, again, you're being really thorough. And I feel like sometimes therapists and prescribers don't always have the best relationships, because certain prescribers either won't really talk to therapists. Some therapists don't want to talk to the prescribers. Sometimes people are busy and just can't get connected. Or there can be almost like a hierarchy, I've noticed at places sometimes, where it's like, we're all a team though. And so, and whichever way, it's not even just prescribers if I've seen therapists be like, well, I see them more, so I don't need to talk to them or get their opinion. And we're all a team. So I like that even the way you're describing your assessment process is similar, but with its own, like, similar to what we would do, but it's with its own edge. Like, you're looking a lot at, like you said, food and some different things that really aren't incorporated in enough assessments, I think.
Yeah, I agree. And I think a person's therapist is the most important resource I can give a patient. A good therapist, and I'm living proof of it. Good therapy changes lives. So I'm really particular about who I send my patients to. And I'm so glad I can be. Sometimes when you work in an institution, you have to send them here, you have to send them there. And, as somebody who's seen the person, that doctor might be good, or that nurse practitioner, this person I really dislike. So having a relationship with a couple people, just a couple people that it's hard to reach people nowadays, but that if I need to ask them or tell them that I see something going on, they're going to listen to me and they're going to value what I said.
Absolutely.
Most important resource I can give a patient.
Yeah. And that's why I would send people to you and not a lot of the other people.
It's not all about medicine. Medicine is just a way to, when people get depressed, if it's genetic or if they have enough stressors, any of us can get depressed.
Mm-hmm.
All it takes is one more stressor for any of us, and we can be right here. So my goal is to stop the brain from doing this. And the only way to do that is to incorporate a good therapist, good nutrition, belongingness, because loneliness kills more people than anything else, no matter what their disease. So the sense of belonging, which to me, therapy helps people branch out with, and the right medicine. So if somebody has, a lot of anxiety, or they're depressed and they're anxious, then to me, I feel like that's low serotonin. It could be low norepinephrine in the brain, but that's why we use serotonin reuptake inhibitors. And the way they work is they block the brain from overusing that chemical so that that chemical can go up to where it belongs and puts them on even playing field. You know, it's, you know, when your serotonin is low, everything's on your last nerve. Oh, it's just, you're not at a good playing field. And it's hard to incorporate. Your therapist can tell you to try this, but if you're paralyzed with anxiety, it's going to be hard to do. So my goal is to use the least amount of medicine, but get people to remission, right? And then keep their brain that way with medicine, therapy, get them involved in all those other things for at least a year. And try it back in it off. Some people genetically, that, you know, like any of us, if you have a genetic, you know, asthma or diabetes, once that gene's on, sometimes it's on. So that's okay. We just maintain you. It's not going to hurt you. It actually stops the brain cells from dying, which depression does. You know, it causes brain cells to die. So it's not life and death, but nobody wants to hear, well, you have to take a med every day. So my goal is to help them try to get off. And if they can't, then we go from there.
Yeah. I love everything you just said. Because I feel like that was going to go into my next question about, you know, for therapists, how do they know when it's time to refer somebody for medication? And I think that for certain therapists, and this is why, like you were saying earlier, doing the work on yourself is helpful, because I feel like for some therapists, if they're like, this client's not getting better, I'm trying this, I'm trying that, they kind of take it personally, versus looking, like you said, at some of these environmental factors, genetic factors. And there's going to be, depending on what the person's going through, sometimes there's going to be limitations to how successful they can be if there's some of these chemical components. So it sounds like for what you're saying is for therapists to know when to refer to a prescriber, definitely if there's, like you said, paralysis, if there's a big, maybe like interference in daily functions, any other categories you could think of where it would be like a red flag, like it's time for medicine?
So I think if someone's depression is mild, studies would show that therapy and exercise work the best. And I've told people, you don't need this, but here's what you can do. But if depression is moderate to severe, I want to stop that. To me, the longer we let that go, the more apt we are to not be able to, in the future, get off the medicine. So if your symptoms are affecting your ability to function in a couple of different places in your life, work, home, relationships, school, then that's when I would say they need to be on medicine.
Okay.
Or if somebody has a history of bipolar disorder, so that's one you don't want to mess with. People with bipolar disorder, 25 to 60% of them will attempt suicide at least one time. And 55% of people with bipolar disorder are going to use substances in trying to manage it. That's going to make it worse. So, people with bipolar disorder, if you just have this about it.
Yeah, absolutely. So it's like an abundance of caution, right? Worst thing is they had this appointment and they found out they don't have it. They used 90 minutes of their time. But if they do have it, then again, with on the therapy side, or anything else that they're doing, they're going to be fairly limited with the amount of success they're going to have with managing their symptoms.
Right. Even people with borderline personality disorder, I think medications are helpful to them to limit that. It's really hard. People have a hard time working with them, right? And rightly so. But if we could think of it as, okay, watching the brain chemicals, because their brain chemicals are just out of balance. And then you can teach them the skills they need, but it's hard to teach them when they're going up and down.
Mm-hmm. Oh, absolutely. It's like you were saying, if the depression's more severe, even some of the suggestions that you would give on the therapy side they might not be able to take a shower. How are they going to do any big coping skills or, things along that line? And like you said, with people with borderline personality disorder, it's like sometimes the moods are fluctuating so much and the distress is so high that some of the skills might not always be either not necessarily useful, accessible to them mentally.
I agree. So
Perfect. That makes sense though. I think being able to, again, on the therapist side, figuring out when is that time. So it sounds definitely like looking at assessing for their functionality is going to be a big indicator.
and yeah, function is the biggest indicator. A major depressive disorder, to qualify, would you would see their function impacted in two different places. And so that's when I think we need to get at it. We don't want to keep this going on. Of course, sometimes patients are reluctant to do so. And so here's what I say. You need somebody that will do this with them. Just go and talk to it. You're not going to push it on you. And oftentimes people that are really reluctant to meds, they just need education on what that depression is doing to their brain. And they need, or, their whole health in general. It impacts coronary artery disease, I think dementia in the future. That's why people, they can't make decisions. It puts people at risk. If you've had a open heart surgery and you're depressed, let me tell you something, the cardiologists, they get up on there because it puts you at more risk to die. So with a little education, then people can make it. And I always say, no, I want you to think about this, come back. And oftentimes I'd say 80% they'll go, okay, I'd like to start a medicine. But I'm not going to push it, but I want them to know they can come back. Why be miserable?
Yeah.
Yeah.
But I like that because I think too, it can feel like if somebody's being referred for or somebody that like the client themselves has been referred for meds, they almost feel like, well, I'm going to have to walk out with a prescription, or they may feel like that's what's being pushed without even understanding why.
That's true, that they have to please you by taking the medicine. I make it very clear up front. I'm just here. We'll go over this and I'll tell you what I think. And then you can make the decision. To me, that's the most important. I give you the information and you're the one that makes the decision with my input. Like, you can't say, well, then I think I need Adderall. If that's not talked about. Which brings me to another thing. Everybody has ADHD. But this is a little off topic, but if you're depressed, you can't focus. If you're bipolar, you can't focus. If you're anxious, your body's responding as if a train is coming your way. Our brain does not want to focus on the train coming our way. It wants it out. So we can't focus. Those things are usually the culprit, or sleep apnea, poor sleep. If you don't sleep well, you will never, ever focus, no matter if you're on Adderall or not. But I get a lot of people that say, well, I'm sure I have ADHD, but really it's most of the time bipolar or depression or anxiety.
Oh, yeah.
I got off on that subject, but I'm not ruling out that there isn't ADHD, but there's a history of that. And so we'll get to that later.
Yeah. That
how these other things are.
Right. And you're right, though. So many of the symptoms overlap. And I feel like whether it's because of, like you mentioned, certain places that people work or certain regulations that they have to meet, or even just, I've noticed sometimes with new therapists, this need to like finish the assessment. I got to answer all the questions instead of really diving into stuff. And then I guess sometimes with insurance too, you have to leave with a diagnosis to be able to bill. So I think sometimes that can create a lot of pressure and things get missed. So I like that you're saying to dig into certain things deeper. Don't take it at face value. Also, there's a lot of misinformation out here, especially with social media now.
TikTok is where everybody gets their
diagnosis. Yeah.
Oh, and they're yeah. So maybe I should watch it more, but there's 54% of what people, might be higher, learn on social media, in particular, is false. So people don't have anywhere to go to verify these claims. So I think that's part of my job, to take what they have, and if I don't know the answer, I'll find it out.
Absolutely.
fact information.
Yes. And that's it. I think there's certain aspects of social media, like you were saying, with that sense of belonging, where sometimes people find these places that they're like, that sounds like me. But I also think sometimes it can go either way. It could be some of the best tools and it could be some of the worst. So it's really, like you said, kind of screening through even who are you following? What's their background? What's their education? How do they know the things they're saying? And is this all like their personalized experience? It's not necessarily like facts across the board.
Right. And as we all know, our personal experiences can impact what we impart to our patients. So myself, I'm always watching myself for that. And for anyone that's new, I would say, do your work. Never stop doing your work, because oftentimes we're triggered. Oftentimes we might want to, go back to what's going on or what happened to us, but it's not fair to the patient.
Oh, absolutely. And I think, like you said, there's just never a point to stop learning. So I think that makes sense. And you have to keep learning yourself, because we're changing too as time goes on.
And having a group of friends that are professionals, who we hang out with, affects our mood. So practicing what we're telling patients to do, like with nutrition, with broadening our scope of friendships, and having mentors all the time. But I always have people that I say that I go to. I go, what am I missing? Am I missing? I'll put it on me first. Am I missing something? Because I can miss something. I'm human. And so I think that is like probably the best advice I could give to anyone. It's people that know it all that scare me. Now, if somebody says, I don't know that, I'm like, that's fine.
Right. I respect you more when you could admit that.
I know nobody knows it,
Absolutely. And that was, you kind of already answered it, got ahead of the game. My next question, which was, why do you think it's important for therapists and prescribers to be able to collaborate?
Well, I when I call the therapists that I work with, I take what they say because I know they're good. I really respect what they see. And then if I have a differing of opinion, I'll say, okay, well, here's what I see. Person might have bipolar. And they'll go, we can go back and forth on that. Or you just have to have someone you can back this stuff up on, because I'm not always thinking I'm right. There are times, as my kids would tell you, but I think working with good therapists who know their stuff, that's where you can, because the therapists do see the patients more often and longer. So their input matters to me. I mean, some of the stuff I learned, like, if this is going on at home, it doesn't necessarily, there isn't a medication that can fix an abusive household. So, so me upping a medicine, or, oftentimes I think I've had many times people come to me and they want benzodiazepines for their anxiety, which in some cases is appropriate. But if you're living with an abuser and I give you benzos to make you not anxious, and I'm taking away what your body is telling you is danger. And what I want is for you to listen to your body. I might, start you on a SSRI because some of it can get too much and people get paralyzed. But we have to trust sometimes what's going on. So sometimes I don't even get that information unless I talk to a therapist.
That makes sense too, because I know I've seen it on the opposite side where the person's telling me all these big new symptoms that they've had. And I'm like, what's changed? And then they're like, oh, everything's kind of been the same. And then I ask about medication and they're like, oh yeah, they upped my dose for this, or they lowered this, or they added this. And I'm like, well, Of course, then you're going to have some symptoms. But, with the clients, they don't always understand these connections and they don't always tell us all of the things that may be relevant because they don't understand what's relevant. So I know it's really helped me before to be able to talk to the prescriber and be like, what are you seeing? Why did you up this? Because sometimes I may not be seeing the same symptoms or they're telling us different things or we're seeing like different sides of the same coin. So yeah, I love that. Like you're saying, there's just certain situations that medication is going to have a limitation. There's some that therapy is going to have a limitation, but together we can potentially really help this person in a whole way.
Yes. And to your point about different stories, I worked in an ER many years. I would go in and I would ask the patient, what are you here for? Blah, 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 blah. I'd go back out. The doctor would go in and it would be like two different people. I don't know why. Human beings just do that, but it happens over and over. So there's two sides that sometimes, even if I'm talking about something that I remember these other things. So I think it's always important to have someone you can bounce this off of. And if you can find someone like that's at your facility that you work with that is workable, that's the best way to do it. Because you can stop them in the hall,
Absolutely. All right. Monthly meetings. Like we would have
meetings. Those were helpful. I
Mm.
would listen to case studies. When we worked in the military, we would do that in big groups, and they were fascinating. I learned more there, especially in that regard, how important it is to come together and talk through this. What might else it be? What's your differential diagnosis?
Yeah. So that's the same thing. For the longest, I was the only therapist at the clinic I was at. And so I didn't have anybody. And you guys were the closest, you and Annette and Renee. And so, yeah, being able to go to those meetings and be like, okay, there's other people here. That was nice.
We were kind of out there.
Yeah, for a long time. And then even when the other people came, they were all active duty. So they were definitely getting a different story than I was getting.
Oh,
Yeah. Very different. But that's why I appreciated you so much because like you said, being able to find those people and the network that we had within in the military, there was so many different people and places and providers. And so being able to understand like who does want to collaborate, who has a similar maybe demeanor or approach or whatever it is, who will fit some of these clients I have that I can securely, because that was my biggest thing is they're really trusting me. And I'm sure you felt the same way. If they're really trusting me to come in and share these things, and I'm referring them for meds, I need to send them to somebody I trust because I can't send them out and them get burned, them go backwards in treatment. So it was very helpful to collaborate. So just years later, thank you for you.
problem. Yes, that was always the biggest concern in working. Freedom, they start on meds and they at least needed to know that, they needed that information. And they also didn't need to be minimized because, when you send them to some people, they're like, go back out on the field, or so never helps anybody.
No, sure didn't. And it is nice to have that collaboration too with obviously for the client, because then they get everything addressed. But I think as a therapist, it was really nice to be able to have people that I trusted, or even because we had the same system, to read each other's notes and just be like, okay, I like how she writes. Perfect. I know what happened in their session.
And I felt the same way about you guys, and that we could call each other and just say, what are you saying? Or what? It's a world of information within that. So, yeah, so you might have to do a lot of work finding.
Yeah.
But I think it's worth starting, monthly meetings with people. You get started on Facebook. We have one here at 757 Therapists, and they meet, and I go. I just think it's helpful.
Absolutely. Because you need that sense of community. And like you said, for burnout, for differential diagnoses, to make sure there's not a bias that you have, and most of our work is done behind closed doors. It's us by ourselves.
Right. And your bias will always come up, or your own stuff can always come up. So we always have to be on top of that. So mentoring, I was saying having a supervisor, somebody to go to, is really important.
For
You know,
sure.
'cause I think they're out of school, and they're like, yeah, this nurse practitioner as well. And I'm like, whoa, 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 whoa. Let's step back a bit. We don't want to be cowboys. Just because we can prescribe a med doesn't mean we should. And so, you know, having other people to bounce stuff off of is, to me, the most important thing.
Absolutely. Yeah. Cause it can get lonely, or there could be times you get two in your head and you need to be like, or my favorite was I would have some doozies come through and be like, oh God, I need to talk that one out because I don't even know what to make of that. So
Yeah. And in talking it out, especially if you have other people who have seen them, it's like, okay, this is making more sense. Otherwise, you feel like, ooh, now I need a
yeah, I need a nap.
time off.
Absolutely.
I would caution people that I see more of it is alarming to me is lack of balance. And that's not just for therapists, but for nurse practitioners as well, for doctors as well. Boundaries, we teach people boundaries. People don't have that in their home. They might not like it when you set limitations, but it's the most important thing we can teach is that we have boundaries. And that means that they can have boundaries. But the lack of boundaries is what gets people in the most trouble. So, and I see it every day. It alarms me. You know, you don't go on people's Facebook. You don't become friends on the Facebook. You know, you don't meet them out for lunch or have them take you to lunch. The stories I hear are just,
We're dating. God, I've heard a lot of that lately.
I'm not sure where we're going wrong in not teaching it. But I do think that a lot of us come into this field with underlying things that we have to always work, you know, or need to fix it, whatever it is. We need to figure out what it is and then work on it. Otherwise, it will play out in these one-on-one interactions. You know, I am not your friend. I am the nurse practitioner treating you. I mean, I care about you, but we can't be friends.
Mhm.
Or ever date. You know, I mean, sometimes people just need to hear it right off the bat. I put that in my part of my informed consent because, and then I go over it with them because people don't understand. It's up to us to understand.
And enforce that. And like you said, we may be the only person in their life who's modeled healthy boundaries for them. That may be the main reason they're in there to work. Maybe part of their depression or anxiety is because they lack boundaries. So they're getting pushed over, or their relationships aren't working out, or whatever else. And yeah, I think that's a big one. Cause I was going to ask if there was any other tips. And yeah, I think that's a very big one. And like you said, over time too, being able to learn, because what we go through in life, at one stage we may be pretty healthy, but then something else may happen and we need to work through that too. So being able to work through your stuff is great.
Exactly. And the question I always ask myself is, whose need is this? And, you know, I don't want to ever do something for a patient that they can do for themselves. That is my rule. Because if I do, I rob them of the opportunity to feel good about doing it themselves. So I always step back because, you know, I'm a doer.
Mhm.
So I always have to put the reins on myself. Diane, who's needed? Um, and you know, sort of empower the patient to do it. That's what the name of my company is, Mana Psychiatry and Wellness. Mana, I was raised in Hawaii, so Mana is a Hawaiian word that means you get your power from within.
Mm.
Truly believe. So I'm providing a space where people can find that power and then grow it, because it's within all of us. We just have to find a safe place to find it. Me doing it for you is not going to help you.
Mm-mm. Oh, I love the name. I didn't realize that. That's so cute. That's perfect. So, yeah, I really like that. And again, I think that that's helpful because like you said, people come into this field. I think a lot of people, they have their own stuff. Maybe they have a big heart. Maybe there's part of them that thinks they're going to heal through the work that they're doing, but then their stuff comes through. And sometimes they might do too much.
I see it every day. And those are the people that get in a lot of trouble.
Yeah. Oh, yeah. And
The board of nursing and the board of social work, they go hard. I'm not going to say that about all other boards.
mhm.
You know, they go hard and people lose their license, and it can happen easily. It's not a judgment, you know, it's just an it's a blind spot that one has, and we all have blind spots. So it's being very vigilant on talking things out with another trusted person that knows a lot and is able to say back to you, that might be triggering something, or I kind of sense, you know, they can tell you the truth with love. But to always stay vigilant with that, because that is the most, to me, it's the most damaging thing you can do to a patient as well. That's to yourself.
Absolutely. Because they trust you.
Right.
Yeah, makes sense. But gosh, you gave a lot of good tips today. And I feel like I don't know, I feel like I learned something too, especially about your assessment process and seeing all the questions that you ask. I'm like, gosh, I wish other people were that thorough in like all aspects of medicine.
Yeah, me too.
Yeah.
So some others.
Yeah. And I think, like you said, collaboration too, that's something I think isn't emphasized enough. In my program or places I've been, that has not been emphasized enough. So I think there's this almost need to prove yourself when you're new. Like, I don't really need the help and I'm out here and I can figure it out, but you don't know everything.
No, and neither does anyone else. So sometimes, like the primary care physicians will say, well, what kind of medicine do you think they should be on? Don't buy into that. Don't buy into operating out of your scope. None, you know, that's their job if they're going to treat this patient. So go figure that out. They have up to date, which I think is a great access, right? But you know, sometimes you'll be asked to do things that you have to know where your scope is. About their neurology drugs. Scope, not going to comment on it. But I will empower them to go back to that doctor and discuss. You know, so that would be my other thing is we always have to watch our lane. You know.
Yeah. And that's our boundaries.
That's right. And sometimes I'll put a person on a med and they'll come back and say, well, Joe or my therapist or this said I should be on this. Which I say, please don't say that. You know, if you think the patient, like I say, Samantha, if you think the patient should be on something else, call me up and tell me why. And then you'll hear, okay, this is why I did it. So then we can have that. But when we tell the patient that, ruins their trust in what I'm doing, or I could ruin their trust in what their doctor's doing. I don't want to do that. If I don't trust the doctor now, I might say, well, I could always go for another opinion. But I'm not going to be that opinion.
Perfect. Yeah. And like you said, keeping your professional boundaries too, obviously with clients, but like you said, with other providers, it's a very slippery slope. And even though people are in this field and you would hope that they would have the boundaries that they should, or that they would know the things they should, that is not always the case. So I love that that's your workaround, is come to that provider directly and ask the questions, or be able to set those boundaries for yourself with what your scope is and have a hard line of, I don't give medication advice. I refer out for that. Or that's your primary care doctor. We have a different process here, or whatever it is.
That's a good question for your primary care. That's a good.
Absolutely.
You know?
Yeah. Yeah, I love that. So I think that that makes sense too. And that's a good note. Again, for all the new therapists out here who feel like they need to have all the answers and, you know, they just need to know everything, do everything. So I think that's really helpful,
and the best providers are the people that know that they don't.
absolutely. Yeah. And they are willing to learn and ask the questions. So yay.
So, good luck, everyone.
Yeah. And I just appreciate you taking the time to do this today. I know that you're busy and
do it. I was just overjoyed to see you again and do this
Yeah. Oh my gosh.
for what you're doing. Because when you're new, it's hard to find these resources.
Mm,
Without
absolutely.
it's nice to get some information that you can take with you and use.
Oh
You
yeah.
got $300.
Right. And I could have used it back in the day.
Exactly.
Yeah. So good karma, pay it forward so the next generation can learn all the things that they need to. But yes, thank you so much for taking the time to do this. I really appreciate it.
And it was so nice to see you again.
You too. So
Virginia and wants to talk to me about patients, give me a call. You've got my number. You can text me.
yeah, absolutely. And I'm going to put your information below as well so people can follow you, see your website, and learn a little bit more about what it is that you do. So for the viewers out here, if you guys want to look in the caption, it'll have Anne's information so you guys can follow on and see what she's up to. But if you want to continue to follow up with me and different episodes, go ahead and subscribe. And I'll see you guys next time. Thanks, Anne.
Samantha. Bye.